Good morning. This is Dr. Nick Tullo from New Jersey and my ECG channel on YouTube, ECG Doc. I also am the creator of ECG Academy, and I'm here on this Saturday morning in New Jersey presenting to you a clinical live stream, a really cool case report about a young man who kept passing out in the shower. And we're going to talk about that in great detail. So for those of you who haven't watched these live streams before, I am a cardiac electrophysiologist. And when I was a medical resident back in 1982, I worked on Long Island at North Shore University Hospital. And back then, when people came to the emergency room after having a fainting spell, we wanted to monitor their heart rhythm because we were afraid that they'd had some kind of crazy heart rhythm like VTAC or something. So we would put them in the intensive care unit. Now at the time we had about 30 ICU, CCU beds. So we'd stick them in there for 2 or 3 days, and if nothing turned up, we generally sent them home. So the evaluation and management of syncope has evolved quite a bit since then. And I've taken it upon myself to be somewhat of an expert in syncope. In fact, about 1/4 of my practice is all about fainting. So if you want to learn more about fainting, I'll actually have a link in the description down below. I have a website known as njfaint.com, and there's a lot of information about syncope, what causes it, the kinds of things we're going to talk about today. But for right now, I'm going to present this case, and if you enjoy this content, please subscribe. There's a link down below where you can subscribe to my YouTube channel and let all your friends know what's happening. So I'm going to try to look at our comments every now and then. Hey, Nicola Vela is here. Thank you very much. Christoph, Tedas, Clemens. Oh, Germany, hi. Guten Morgen. So I'm very happy to see 9 people watching, and anybody who has questions, I'll try to remember to look over to the comments as often as I can. So I'm going to, since this is a case presentation, I'm going to give you some history here. So this was a patient that I had seen 3 years ago. And so I know what the outcomes are, and that's kind of the cool part about this case, is that I can tell you how things turned out. So it's going to be fun. Anyway, this was a 28-year-old fellow. He was in a stressful job, was an insurance claims adjuster or something like that. He had a history of ADHD and was on Adderall for that, but no other medical problems, no hypertension or diabetes. And I had seen him in consultation in my office because for the last year or so, he kept having fainting spells, mostly in the shower. I mean, he would be in the shower. He'd feel sort of sometimes a slight warning of a little bit of lightheadedness, maybe felt queasy, maybe a bad taste in his mouth, but it was only seconds. And the next thing he knew, he would be waking up on the floor. He'd be crashed to the ground. His girlfriend at the time was very concerned because she'd hear this crash and she'd come running in and he'd be on the floor soaking wet. And luckily he'd never injured himself, but he would wake up pretty quickly. These episodes would only last about a minute and he would feel relatively normal afterwards. And they got a little bit more concerned when he passed out one time while just sitting in the living room, and he actually was incontinent of urine. And so they brought him to neurologists, and he had a big exam, and there was CT scans and MRIs. Everything was normal. They did an ambulatory EEG, because when someone has urinary incontinence, well, people sort of assume, oh, maybe it's a seizure. So they had actually placed him on Depakote empirically, despite the fact that his EEG was normal. Imo from Saudi Arabia, hi. And Steve and Katie and Ricardo Virelli, buongiorno. So we're talking about this fellow who was passing out with very little warning, mostly in the shower. And he even tried taking like cool showers. It wasn't just that the temperature was hot. So at any rate, he went on Depakote for 3 months and actually did pretty well. He was symptom-free for almost a year. And then he was in the shower And then he passed out again. And this time, his girlfriend noticed his arms and his upper body were shaking. He was incontinent of urine, and he really had no nausea at the time. So it really became a bit of a problem. You know, he'd seen cardiologists in the past, but they never found anything. He had an echo. He wore a 24-hour Holter monitor. Nothing showed up. And since that point, he had a couple of episodes while at work. So he finally came to see me in consultation. And I can tell you what his ECG looked like. It's right here. So we're looking at a normal sinus rhythm, you know, with a rate of a little above 60 beats per minute. The axis is normal. The QRS maybe is a little bit wider than 80 milliseconds, but nothing really to write home about. His QT interval is normal. You really want to check that QT interval, right? Because people with unexplained fainting, you have to rule out long QT syndrome. That should be my next clinical chalk talk, my clinical live stream, because that is a poorly understood situation, because sometimes you can actually have long QT syndrome with a normal QT interval. So anyway, I kind of felt that, well, what do you guys think? I mean, here's a young, healthy guy with a normal heart, a normal brain, and he keeps having these fainting spells. So it's a bit of a puzzle because we don't really know what's happening. Now, in the old days, we would think that maybe it was vasovagal syncope. And in fact, that is the most common cause of fainting. About 2/3 of all faints are due to that mechanism, so-called reflex syncope, where your autonomic reflexes become temporarily disturbed and you have either a drop in blood pressure and or a drop in heart rate. And with a sudden decrease in blood flow to the brain, your brain stops functioning. So it's so vasovagal syncope was probably the number one diagnosis at the time, and I decided that this fellow really needed to have a diagnosis so that we can try to treat it. I mean, he had tried drinking lots of fluids and tried, a high salt diet and so forth. And Nicola seems to think that maybe when he tilts his head back in the shower, he restricts his blood flow. That would be sort of like this carotid sinus hypersensitivity syndrome. And that's actually a good thought, although it's much more common in older people who have atherosclerosis and who have stiff blood vessels. But that's a pretty good thought. So you kind of have to. But then why would he pass out just sitting, in his living room, just sort of like watching reruns of Housewives of New Jersey? So we had to try to figure out what was wrong with him. So what do you think you would do in this situation to try to establish a diagnosis? Anybody want to raise their hand? I can't see any hands. Oh, it's always the same hands going up every time. Come on, somebody new, please. Just teasing. What I recommended was something that we do in patients who we suspect might be having vasovagal syncope, and that's a tilt table test. So a tilt test, for any of you who haven't seen one, is basically an orthostatic challenge. We place someone on a flat table with a footboard, and then the table tilts up to an angle generally of about 70 degrees. I'm looking at myself, so 70 degrees is about here, right? Okay. And you can see, I'm going to show you on my screen what a tilt table test looks like when the patient's up at 70 degrees and they're standing on this footboard and they're securely fastened to the table with seat belts so they can't fall or anything. And we have them monitored. Most people monitor the heart rate and a pulse oximeter, and they put a blood pressure cuff on the arm. I actually am lucky enough that I got the hospital to buy me a gadget, which is a finger manometer. I don't want to have people complain that I'm trying to sell things, but So I won't mention the company's name, but it actually measures the digital blood flow through your finger, and it can give you blood pressure almost like an arterial line on a beat-to-beat basis. So you can see changes in blood pressure within a couple of seconds. So it's much better than relying on a sphygmomanometer, which takes 30 or 45 seconds to pump up and measure. And during a tilt test, if someone does drop their blood pressure, by the time you pump up the sphygmomanometer, it may miss it. You get this reading like error, and you never get the number. But with the finger pressure, we actually did this tilt test. And let me show you the results of this tilt test. Maybe you'll be surprised. So here are the results. And this is, I'm pretty compulsive. I try to measure all vital signs every 2 minutes. And what you notice that supine, his heart rate was about 70 beats per minute. And then as soon as I tilted him up, it went up to 87. And his blood pressure really didn't drop much. In fact, the blood pressure went up a little bit. Systolic 124/83. So his blood pressure went up a little bit. He doesn't have orthostatic hypotension. But by 6 minutes, his heart rate had gone up by 30 beats per minute. So anybody know what that's called? There's a little bit of a lag on this thing, so I have to kind of wait to see if someone actually puts a comment up there. But this is sort of postural tachycardia. Now, he doesn't really have the typical symptoms of POTS, or postural tachycardia syndrome. He doesn't complain of constant lightheadedness and chronic fatigue and palpitations or anything, but this is kind of an important finding. Nicola, you're absolutely right. Good, that's terrific. I have another quarter of my practice as patients with POTS. Isn't that crazy? I'm the POTS doctor of New Jersey. Lucky me. These patients are sometimes very difficult to manage, and most of them are young women that have become like completely disabled by these symptoms. But he did have this evidence of postural tachycardia, so his physiology is struggling to maintain normal circulation in the setting of this orthostatic challenge. But here, 10 minutes and then 14, and he remains with a heart rate of about 110 to 120. His blood pressure is completely stable. So then I started isoproterenol. Some people during a tilt test will give sublingual nitroglycerin. Well, I kind of like using isoproterenol. I got his heart rate to come up to about 135, 145, but his blood pressure went up, and he completed the whole entire test without any lightheadedness. There was no syncope, there was no sudden bradycardia, there was no hypotension. So it was essentially a negative tilt test for vasovagal syncope. So at this point, what would you do? Now, what's the yield of a tilt table test in someone whom you suspect has vasovagal syncope? It's probably about 90%, especially if you use adjunctive medications like nitroglycerin or isoproterenol. And so in someone who has vasovagal syncope, 90% of the time you can actually reproduce it. In his case, there was nothing. So we still didn't know what was happening. And so I recommended something that we're using more and more. In fact, these implantable cardiac monitors are extremely useful in people who have infrequent symptoms where you suspect they may be having an arrhythmia. So an implantable cardiac monitor or an implantable loop recorder, ILR, however you want to call it, is a battery-operated device that goes under the skin. And I've implanted quite a few of them. I actually published a couple of abstracts on implant techniques. And I want to show you a little video that I did. This is one of the first ones that I was actually the first one to implant this particular monitor in the Northeast and maybe even in the US. The day that it was approved by the FDA, I got to implant one. So here we have it's prepped and draped, and we have anesthetize the patient with 1% lidocaine, and I use lots of lidocaine. Some people are doing this in the office, but this was in the cath lab. So here's the technique. I don't use the puncture stab tool that comes with the kit because I think it does a lousy job. So a tiny little stab, 1/4 of an inch or so, with my scalpel, and then we create like a little track with this insertion tool, and then it's like a little plunger that advances the device under the skin, and that's it. See, 30 seconds. Ta-da! It's really, really simple, straightforward, and they're very, very effective in diagnosing intermittent arrhythmias. Most of the patients don't even know that it's there because it kind of disappears in the fat. It's very light, and it's about the size of a paper clip, so it's really pretty small. So unless someone's really, really thin, it may even have a hard time finding it, and so patients really enjoy not having to wear monitors. Besides, how are you going to have somebody wear an event monitor when their symptoms occur in the shower? Right? I mean, you're supposed to take the event monitor off when you go into the shower, so that became a little bit of a problem. And back then, about 3 or 4 years ago, the event monitors. Nowadays, we do have patch-style event monitors, and so that might have been useful. You could stick a patch on, but his episodes were occurring rather infrequently, so you'd have to give him like 2 months worth of patches, and so this turned out to be a very useful device to implant. And Matilda from Northern Arizona. That's great. How's the weather out there? You guys are cold in Northern Arizona. Isn't that sort of up near the mountains or so? But I'm glad you really love my classes. Thanks very much. And Kareem, thanks for joining me. I'm glad I sent out a whole bunch of emails last night. So whoever got them, I appreciate your stopping by and watching. So we put this monitor in and sent him off on his own, and about a month later, he had another fainting spell in the shower. So we interrogated his device, and this is what we found. Drum roll, please. Welcome to the Flatliners Club. So here we have this is actually a rhythm recording from the device, and it does have these VS markers that tell you what it's seeing. And you can see there's a slight slowing of the heart rate right around here. Oops, for some reason I'm not. There we go. And then slowing, and then look at that, asystole. Asystole that went on and on and on and on until finally he sort of like has a little junctional escape beat, a couple more, another junctional escape, and then he's sort of back in a sinus rhythm. So he hit the ground hard, and now you know why. So just as an aside, how long of a pause does it take for someone to lose consciousness? That's a really good question. But it was, Bradley, never mind. Never mind. How long does it take for someone to pass out? Well, back in the 1950s, I think, there was an article that got published, and I have photos from the article because it blows your mind. But there's a bunch of neurologists decided to do an experiment, and they designed an apparatus that was essentially a blood pressure cuff that could inflate within 1/10 of a second up to a pressure of 300 millimeters of mercury. But they put it around the patient's neck, and it was operated by a push button. So when you push the button, it would instantly inflate and completely cut off blood flow to the brain. And the idea was that how many seconds did it take before the person, the subject, loses consciousness and lets go of the button? Okay, so pretty crazy, right? But back in the 1950s, we didn't have a lot of institutional review boards. So at any rate, it turns out that the median time to loss of consciousness was about 6 seconds. So there was a bell curve, but the median was about 6 seconds. Some 4, some 10. But, when you start to see pauses on a monitor, like if you're at the hospital and the telemetry tech calls you up and says, "Oh my God, Dr. So-and-so," or, Nurse Jones, your patient in room 1105 had a 2.5 second pause. 2.5 seconds, most people wouldn't even notice it. But when you get to 4, 5, 6 seconds, that's when people can pass out at just, without any warning. And that's what was happening to this fellow. He was having, now this isn't sick sinus because his Holter was normal. There's nothing wrong with his sinus node. What do you think this is? Okay, this is known as Katie 6 seconds. Excellent. So this is that's right, Dinesh. I didn't want to mention this, but when they did that study, they got a bunch of volunteers to become subjects of that study with the push button. They got the volunteers from the local prison. Right? I mean, after all, what better place to find a bunch of volunteers? So yes, that's right. It was a bunch of prisoners. The interesting thing is that there were a couple of subjects, a couple of volunteers who decided they didn't want to press the button because they had to do it like 3 times. Then they took the median, they took the average time for the 3 attempts. Of course, they were scientists, right? They wanted to get good data. So when those subjects that decided they didn't want to press the button, the investigator pressed the button. And they actually found that they were able to stop blood flow to the brain for up to 100 seconds. And when they finally, and the patient passed out, they started seizing, and it looked awful. But when blood flow was restored, they reported that there were no long-term consequences of loss of blood flow for up to 100 seconds. Woohoo! Boy, that's really an important contribution to science, wasn't it? At any rate, yes. Amanda, he did earn himself a pacemaker. Hey, nice to see you here. But first, I didn't just tell him, he was only 29 years old. You want to give a guy a pacemaker like that? I mean, gee, he wasn't even married yet. Maybe his girlfriend was going to leave him because, she didn't want to have to call him lumpy. So we tried a bunch of things. In fact, here, I'm going to show you what we tried. So we tried, get rid of this. We tried Florinef. That didn't help. I put him on Midodrine every 4 hours. Take it an hour before he gets into the shower. He still had episodes. I even tried Ivabradine because he had like a little tachycardia before he'd pass out. Didn't work. We even tried a beta blocker. Even though sometimes you get a paradoxical improvement with beta blockers. No, I tried an SSRI, and he kept having episodes. And here's another example. So this was a different episode that occurred. And you can see, again, you have a little bit of tachycardia here now where the rate's about 100, maybe 90, and then it gradually slows down, and then you have this, long period of asystole. So we eventually said, look, sorry, but I think the pacemaker is probably the best thing. Now, is there any data in pacemakers and syncope? Well, there is a lot. In fact, there's a huge amount of data and studies that were done to see if pacemakers should be given to patients with syncope. Initially, there seemed to be some positive data that showed that pacemakers reduce the incidence of syncope. And yet, when they repeated the study with a placebo group, where they actually implanted a pacemaker but didn't turn it on, it turned out that those patients seemed to benefit as well. So the conclusion was that there was a huge placebo effect in just implanting a pacemaker. You just implant a pacemaker and don't turn it on, that patients still actually benefit just from this placebo effect. So there have been a lot of other studies to show that pacemakers don't really help in syncope, unless you can demonstrate that you have this cardioinhibitory component to syncope. Now, what do I mean by that? So when you have vasovagal syncope, when you have reflex neurocardiogenic syncope, whatever you want to call it, there's sort of two components to it. There's the vasodilatation and hypotension that occurs because of sympathetic withdrawal. And that's known as the vasodepressor part of it that causes hypotension. And that's very common. Most people get a degree of hypotension. But there's also the cardioinhibitory part of it, and that's the severe bradycardia that can occur. And that, again, is maybe sympathetic tone, maybe the vagus nerve fires. It's not really clear why some people, but about 10 or 15% of vasovagal fainters have this profound bradycardia, this cardioinhibitory syncope, we call it. Most people have both. Most people have sort of a mixture of both, and there's a wide spectrum of which is, in his case, we found this cardioinhibitory syncope. Now, sometimes you'll tilt people and they'll become asystolic. I had one woman become asystolic for 75 seconds. She was a midwife, and she wound up with a pacemaker as well. But the interesting thing is that there's one study that shows that the people most likely to have cardioinhibitory syncope captured with an implantable monitor are the people who had a normal tilt test. Okay, so that's one clue. If you have a normal tilt test in someone who has sudden loss of consciousness, you really have to monitor those patients long term. If not if they're having frequent episodes, you can use an event monitor perhaps, but an implantable monitor becomes invaluable because many of those people with sudden syncope, sudden loss of consciousness with no warning, will wind up having this cardioinhibitory syncope on an implantable monitor, even after they've already passed a tilt table test. So yes, I did implant a permanent pacemaker in this fellow, and he's actually done really well. It's actually been 2 years. I saw him in the office just last month, and he admits that he's not drinking as much water as he should. He's not eating as much salt as he should. And every now and then he might get a little lightheaded, but he's never fainted since we put the pacemaker in. So I would consider that a success. Now, there is one study that called the issue. There's an issue 1, an issue 2, an issue 3 study. The issue 3 study, which I'm going to show you here, was done in patients who had documented bradyarrhythmias during syncope. So this is a very select population of patients. These are patients who had either on a tilt test, profound bradycardia or asystole, or on an implantable monitor had documented bradyarrhythmias during syncope. And they implanted pacemakers in all these patients. There are about 80 of them or so. But they programmed half the patients on and half the patients off, and it was randomized which one they would do. And you can see from this graph that both groups had recurrent syncope to a certain degree. You can see by 2 years' time, patients who had the pacemaker turned on, about 25% of them had a fainting spell. But in the people who had the pacemaker turned off, you can see that a much larger number of patients fainted, like 60%, close to 60% anyway. So it seemed that there was a significant difference between these two groups, that it seemed that it was reasonable to recommend a pacemaker in people with syncope and significant bradycardia, because pacemakers may not eliminate all the symptoms, but it certainly seems to blunt the symptoms that are there, and many patients will enjoy relief from this really serious symptom. I mean, people who pass out, it really significantly affects their quality of life. I mean, they have difficulty staying on a job, especially if they have to stand on their feet a long time. I mean, imagine as a doctor or a nurse, if you were prone to fainting, and there you are making rounds or doing surgery, and or you're on the nursing floor and you're trying to like take care of your patients, and you start like feeling lightheaded, and next thing you know, you're looking up at 8 people surrounding you. It can really adversely affect your life. So we try our best to identify the cause and try to fix it as best as we can. And sometimes people have to live with it, but certainly when you have sudden loss of consciousness, if you have loss of consciousness when you're supine, someone who has prolonged period of loss of consciousness, they take a long time to come back again, or if they have seizure activity during syncope, those are all predictors of serious bradyarrhythmias or serious cardiac syncope from an arrhythmia. So those are the people that are most at risk of injuring themselves, hurting themselves, and you really have to aggressively pursue a diagnosis in those patients. So what pacemaker settings are used, Bradley? We actually use a device that has a sort of what's called a rate drop feature, so that if there is a sudden drop in heart rate, it will pace the patient at higher rates. Some pacemakers have that. There's one pacemaker made by one company that actually has a feedback loop that allows the pacemaker to pace at faster rates if it sees changes in contractility of the heart. So with a burst in sympathetic tone, the pacemaker will actually pace faster, and that seems to be somewhat effective in reducing the symptoms of syncope. So I think I had left it, since he's a pretty active guy, he generally runs heart rates in the 50-60 range. I think I left his low rate limit at 60, but if he goes from like 80 down to 60 within like a 5-second period, then the pacemaker will kick in at a much faster rate, like a rate of 80, with the idea that a faster heart rate may compensate for any drop in blood pressure that you may have, and that's why that feature sometimes tends to work. Well, Tedessa, I hope your students are enjoying this discussion. I tried to make these Saturday morning clinical live streams more clinical, and not just this is how you read an ECG. So this was a case where the ECG didn't really give us the answer. It was all about how to manage patients with syncope, especially those who are having serious problems. Some people have referred to this as malignant vasovagal syncope, where people pass out so quickly that they're prone to injury, they can get into car accidents, things like that. So you really kind of have to keep an eye open for these particular patients, because they really do deserve an aggressive workup. So I'm glad that you guys enjoyed this presentation. I hope to do another one next week, since I'm not on call for 2 more weeks. But if you have any other questions, you can always leave a comment in the below. And remember, if you like this content, just subscribe to my YouTube channel, ECG Doc, so that you'll get notified that that I'm doing a live stream. I'll try to do it the night before if I kind of have an idea of what I'm going to talk about. Most of these are just off the cuff. And if you're interested in learning how to read an ECG and learn from my expertise, I also have ecgacademy.com. There's a link below that you can check that out. And you can go through a formal course. We give CME credits to certain healthcare professionals. So check it out. And until next week, this is Dr. Nick Tullo. And thanks for watching. Thanks for logging in. Thanks for spending your Saturday morning with me. And hope you have a terrific week. See you next time.